So today we're going to talk about mostly hematology dysfunction, a little bit about immunology, but a big focus on blood disorders in the pediatric population. Some of this that we'll talk about, you have talked about before, especially in MedSurg 1, things like anemia, sickle cell anemia, but some of it will be new, like hemophilia is a big focus in pediatrics, although you'll see it in adult medicine as well. So when we're talking about assessing for dysfunction, especially related to blood disorders, the CBC or the complete blood count is kind of your gold standard for assessing those potential abnormalities. And it can tell you anything from that they have an acute infection all the way to a more chronic disorder like sickle cell anemia or your hemophilias or even that they have an acute bleed or leukemia, for instance. So it can really tell you a lot. On page 1272 in your textbook, there is a really good table that gives you the normal values as well as the descriptions of what those values mean to you. So I would recommend definitely that you, if you have not learned your big components of your CBC, that you should definitely learn those. Some of the things we don't always focus on in nursing, like for instance, in a minute when we talk about anemia, is the MCV or the mean corpuscular volume. Now, as nurses, we're not evaluating that, but you should have an idea of what that means as a nurse. You should see if it's altered. What could that mean potentially, for instance, what type of anemia is it associated with? So that table in your book is a really good description of your CBC components. So some other things we're looking at, we can get history, physical exam, things like skin assessment. Skin assessment is a big part of hematology, things like petechia and pallor and those indications of abnormalities. Oftentimes, for instance, ITP, idiopathic thrombocytopenia purpura, which is just where you have idiopathic changes in decrease in your platelets. You see it more often in children than you do in adults, but it can happen in adults as well. The symptom that brings parents in to have them seen is just petechia. And it's not always obvious petechia. One child I had one time, the child had yawned and the parent happened to see some red dots in the roof of their mouth, and it was petechia that indicated that they had this problem. So not always obvious, but your skin assessment, your vital signs can indicate a lot. There's a lot of different history and physical exam components that can give an indication of problems. Comments regarding lack of energy. A lot of times the first symptom of anemia that patients notice is fatigue, and this happens in both adults as well as children. So if parents notice that they're kind of sluggish, they don't want to play as much, that could be an indication of a big problem. Food diaries. It's not always a dietary cause of when patients have abnormalities in their RBCs or various different blood disorders, but it could be. Frequent infections, that could be an indication of things like leukemia or other immunologic dysfunctions, and of course, bleeding. So the first one we're going to talk about, which is probably one of the most common hematologic disorders in not just childhood, but adults as well, is anemia. So anemia just means you have less red blood cells than normal. So this could be anything from you just had a hemorrhage to you actually have a disorder to you're not consuming enough components to make those red blood cells, such as folic acid and iron. So all this means is there is something causing you not to have enough red blood cells. There, again, are various different causes. We'll talk about in a second the three kind of big branches of causes. So when we're talking about chronic anemia in children, the reason this is more substantial in children than adults is because children are still growing. And kind of like what we talked about with the fetus that has decreased oxygen and nutrients, is where you get that intrauterine growth restriction in children even after they're born. They can have reduced growth and development if they have a chronic anemia problem, whether it be from intake or whether it be from things like sickle cell anemia, whatever is causing their red blood cells to not have optimal oxygen carrying capacity because there's not enough of them, can result in those permanent growth and development problems. And this would be an additional concern you wouldn't see in your adult population because they are done growing. So in children, I know in adults we usually use around 10 to 11 when we're talking about anemia, and that's more of your mild anemia. In children, usually we go maybe a little bit further down. 8 is that big concerning number because at that point you have such a reduced cardiac output of red blood cells that your body is going to start compensating and shunting blood away from your peripheral extremities to your vital organs. So that's when you can start having issues with impaired perfusion of your extremities. And this is when you can start having things like pallor, like you see in the picture. Now, the picture on the left that is normal blood, picture wise, it does look a little ruddy or red, almost like a polycythemia. But the picture on the right is definitely a little pale. Where you wouldn't have as good of oxygen carrying capacity as red blood cells. So when we're classifying anemias, there's 3 kind of broad categories. Either you have like an acute red blood cell loss, for instance, a hemorrhage. This is an acute this instance kind of moment. This isn't a chronic kind of thing. So it could be epistaxis, like it limits a nosebleed. This could be that ITP I mentioned where they're having bleeding from the low platelets. It could be disseminated intravascular coagulation from some major threat to the body. So for some reason, it could be that postpartum hemorrhage. It could be anything that's causing them to lose red blood cells acutely. So that red blood cell loss. But most of what we're talking about with more chronic anemias is either there's a problem in the factory producing it or in the garbage trucks destroying it. So with production, the most common one we think of, especially in pediatrics, is your iron deficiency anemia. So the bone marrow is not producing enough red blood cells for some reason or another. It could be dietary, like if they have low iron or folic acid intake, or it could be that they have leukemia and that marrow is not making those red blood cells at the capacity it needs to. So it could be various different things. When we're talking about destruction or the garbage trucks not destroying them too quickly, this is when you think of your sickle cell anemia. That is the most common destructive anemia in childhood and in general. So this is where those red blood cells are abnormal. So the spleen is clearing them out more rapidly, or they just don't function to the capacity they need to. So it could be a production issue, a destruction issue, or just something causing a loss of red blood cells in the acute phase. So we are going to focus on one production anemia and one destruction anemia because those are the most common ones in pediatrics. And the one we're going to focus on for a production anemia is iron deficiency anemia. So there is some cause of iron deficiency. It could be, most commonly, it is related to intake, but it could be something to do with absorption. Like you will see this, for instance, people that have GI disorders, like somebody that has lactose intolerance, for instance, or has a milk protein allergy. You can see where they can have an anemia because even though their problem isn't with the iron, they have a small GI bleed because of the irritation. And that can cause that anemia as well. And their body is not absorbing the nutrients from those foods, including iron. So it could always be not just that they have inadequate intake, it can be inadequate absorption as well. So one of the most common reasons we see iron deficiency anemia, especially in your older infants and your younger toddlers, is what we call milk baby anemia. And what this is where they're getting too much cow's milk or animal milk that is not from humans. So in infants, this happens because they're getting cow's milk or animal milk in general. Patients should not have anything but human milk or formula until 12 months because milk is a poor source of iron and they need those adequate iron intake up until then, and they're not going to get it from other foods. That's a big reason, the biggest reason why you should not start cow's milk, goat milk, any kind of animal milk before 12 months, because they're going to get potentially anemia from it because of they can't absorb it. So it's kind of the same thing in toddlers. It's not because they shouldn't drink milk. Once you hit 12 months, they can drink milk, but some children get too much milk. Milk at this point should be an addendum to their diet, so to speak, not the majority of their diet like it is in infants. So by toddler age, most of their intake or their supplement, their nutrition is going to come from the food they eat. They can eat a pretty adequate diet to get their nutritional needs. So this should be more as a supplement, not the main source of their intake. So there sometimes parents give them so much milk that children are not eating food to the capacity that they should. And milk again is a poor source of iron. So if that's their main source of nutrition, they're not getting that iron. So this is a common cause of it in children, your older infants and your younger toddlers. Um, so hopefully by now y'all know the symptoms of iron deficiency anemia. So things like pale skin, fatigue. You can start seeing with chronic problems the same symptoms like you see with protein deficiency, like the brittle hair, nails, and things like that. Um, they can even have, like I'm talking with the milk baby population, sometimes you'll see where they're really overweight because they're getting a lot of calories from that milk, but they're not getting good nutrition source calories from that milk. So you may see that obesity as well. So our treatment for this, one is encouraging a good diet, but at that point, once they show anemia, they will usually administer iron or ferrous sulfate is a supplement. So you should hopefully by now know how to administer ferrous sulfate to a patient. But in case you don't, let's talk about some of those standards. So when we're talking about this younger population, they're not going to be getting the pills, they're going to be getting liquid iron. So when we're talking about liquid iron, if you've ever seen it, it's a blackish color and it's dark. So it will stain the teeth if it touches the teeth. So the best method for taking iron is if they're old enough, they should drink it through a straw, give it to them through an oral syringe where it's pointed towards the back of the mouth so that it's minimal exposure to the teeth. And then it best is to brush or at least use mouthwash immediately after to flush out as much of that medication as possible out of the mouth because it will stain the teeth over time. It's very common to have GI upset. So while iron is best taken on an empty stomach at best, what's even better is that they can tolerate it. So it is okay to, especially in the beginning when they first start taking it, if they're not tolerating it, if it's giving them an upset stomach, making them throw up, things like that, they can take it with a carbohydrate snack, such as crackers or something, and that can often help with decreasing that GI upset, but best is on an empty stomach. Things that improve absorption are your vitamin C products. So we kind of talked about this with maternal, with the diets that women should have with folic acid and iron deficiency and things. But anything with vitamin C, it doesn't have to be orange juice. That's what we automatically think of. But a lot of your citrus fruits, grapefruit's another good source. It could be juice. It could be the fruit itself, but some kind of vitamin C product along with it is great. But what should be avoided is any kind of milk products or even anything heavy in calcium. So even those leafy greens we talk about that have some calcium, those can inhibit absorption if taken in enough at the same time. But especially anything you drink it with, like your milk. So those are the big important things regarding iron deficiency anemia, as well as the treatment methods of administering iron. And a lot of that's not going to change whether you're talking about adults or you're talking about children, except for that milk baby potential and the growth and development related to that chronic anemia, which can occur. So, our most common destructive type of anemia is sickle cell anemia. Most people, even if they don't know what sickle cell anemia is, has at least heard of sickle cell anemia. So, what happens with this? It is a genetic disorder. It is an autosomal recessive disorder, which means you have to get the trait from both parents in order to have that disorder. And then at that point, you have a 25% chance of having a child with the disease. So, what happens in this is where the bone marrow produces these RBCs, and when they come out of the bone marrow, they're normal shape, that normal donut shape, like you see in the top of that picture on your right, that slide through nice and easy. But some of these RBCs will then conform to what we call a sickle shape. That's why it's called sickle cell anemia. It's that curved kind of shape. And what happens with these is because of their shape, they get clumped together, especially in areas of bifurcations, areas where you have turbulence, like you see in the picture. Think of it like when you have the Christmas tree hooks and the thin ones that you put on the tree. When you group them all together, they all kind of get stuck together, especially with the way that they're curved. Think of these red blood cells like that. Because of their curved and they're thin, they all kind of get hung together. And when they get hung together, they create a clump or a clot in the circulation. When you have a clump or a clot in circulation, blood can't flow through. So this is why sickle cell anemia patients, when they are in crisis and get that clotting, they have pain. They have intense pain, because that intense pain is caused by some kind of hypoxia. So hypoxia to whatever tissue is distal below it. So they'll get leg pain or whatever it is. And that's because that's where they're having a problem with blood flow. Pain is your body's way of screaming for help. When you have a heart attack and you have pain in your chest, that's your heart screaming, I'm not getting enough oxygen, help me. This is the same thing in sickle cell anemia. When they get leg pain, it's their leg screaming, I'm not getting enough oxygen, help me. So that's what is the big cause of their pain, is where they're not getting blood flow to an area. There are a lot of things that can cause your sickle cell anemia crises. The most common one you should know is dehydration. Patients who have sickle cell anemia are very much promoted. They need to drink, drink, drink all the time. When I worked in the prison system, that was probably the first order that got put in by the doctor, is that these patients should have a pitcher of water in their cell with them at all times. Usually most of the inmates weren't allowed to have fluids, except for these. They had to have fluids all the time. Hydration is probably one of the most important things you can teach a sickle cell patient, to prevent crises. Even when they have a crisis, there's two big things we treat them with: pain medicine and fluids. So fluids are absolutely super important to these patients. When we're talking about other causes, it could be anything that's like a physical or even mental stress on these patients. So when they get sick, it's a bigger deal to them, not only because they have often splenomegaly, which is an enlargement of the spleen, because of the spleen having to process all these deformed cells, but also because they just have this involved splenic function. So when they get sick, not only do they have more trouble fighting that infection, but the infection can send them into a crisis. So infection can do it, stress, exposure to cold. They really need to bundle up, because what does cold do? It makes cells clump together. One thing, when you have an injury and you want to stop the bleeding, you put cold on it to stop the bleeding. Well, you don't want to do that in the sickle cell patient, because it's going to cause clumping. Changes in altitude, for instance, just that change in the air pressure can cause them to go into a sickle cell crisis. And it's going to be your more acute changes. For instance, you can have people that live fine in Virginia with sickle cell, and you can have people that live in Colorado just fine with sickle cell. But if they have to take a plane ride to one or the other, that could send them into crisis. So it's those sudden changes in altitude that can create a problem. So I've already really talked about a lot of the pathophysiology of sickle cell. So it has to do with the cells that are they turn into this sickle shape. So when they're that sickle shape, they cannot adequately carry oxygen on them, on those type of cells, so they're not functional. You also have where your body is destroying these cells more rapidly. The membranes of these cells are often more fragile, so even the ones that are the nice donut shape, that don't become sickle shape, they're still fragile and get easily destroyed. So this is a destructive disorder where they don't have good functioning cells that to carry hemoglobin to the body. So they have a chronic hypoxia to the cells, especially when they are in crisis. So again, the sickling in those cells, they can clump together and they can cause lack of blood flow, causing a more succinct hypoxia to those specific areas. And that's often where they will get pain. So typically these patients live at a lower hemoglobin than us. Their hemoglobin will often be anywhere from 6 to 9, and they live there. That is their baseline. So at baseline, they may often be pale. They may often have fatigue, and their body compensates for that. But they don't have much room to go if their hemoglobin drops. So if their hemoglobin normally is at around 8, and they drop down to 5, we don't think of a drop of 3 as that much, but that they don't have a lot of room to go. So often these patients get a lot of blood transfusions, and are exposed to a lot of additional iron, and things like that. There is a lot of complications associated with having sickle cell disease. So when we're talking about diagnosis and management, so diagnosis is initially started with that universal screening test we talked about when we talked about maternal newborn, where they test for multiple genetic disorders. Again, this is just a screening tool. This just indicates more testing needs to be done. So at that point, they will do genetic testing and see if the patient has the disorder. In order to get the disorder, they have to get that gene from both parents, because it is autosomal recessive. So management, most important thing we're going to talk about, management of these patients. So the biggest thing is to prevent sickling, because sickling is what causes pain crises. Pain crises are not just they're in pain. It is serious emergency. Yes, they're in pain and you want to treat their pain, but also their pain is caused by hypoxia, especially your more severe type pain, like chest pain in them is what we call acute chest syndrome. They are not getting adequate blood flow, and it's a huge deal when they hit acute chest syndrome. So the biggest thing, prevent sickling, prevent infections, keep them well hydrated. All of these things are very important. These patients will be on prophylactic penicillin until the age of 5, all of them. So they will be on a low dose prophylactic penicillin until the age of 5 that they take daily. That is important. That's something you don't see in the adult population. And this is to prevent infection, because it can hit them so dramatically. It's very common for children who have sickle cell anemia to end up having to get their spleen removed because of their splenic involvement with, think of your spleen as like the garbage trucks of your body. All your blood cells as they come through, there's a shelf life of your blood cells. So as they come through and the spleen sees, oh, this one's getting old and defunct, it'll start causing that phagocytosis and getting rid of those cells so that we can make new cells that function more properly. So that spleen is working even harder because there's a lot of impaired cells coming through there. So it does lead to often splenomegaly, an overworked spleen. So it's common for them to have to get their spleen removed, which further increases the risk for infections. So up to age 5, they get prophylactic daily penicillin. Also, I talked about a little bit, but didn't go into detail, how infection can greatly inhibit them, not just because of the sickle cell crisis, but depending on the infection. For instance, take a respiratory infection. If you and I get a cold, we just have a cold, we use comfort measures and we get over it. If you have a patient with sickle cell disease who gets a cold, not only are we concerned because it could send them into crisis, but you have a person who's already has chronic hypoxia to their tissues. Even if it's not a super hypoxia, they have a reduced oxygen delivery to their cells. Then you put on top of it chest congestion and reduced oxygen intake, that further increases that. So any patient with sickle cell anemia should report to their doctor if they have a respiratory infection, if they have a fever, any of those severe types of infections that can lead to dehydration, that can lead to sickle cell crisis, that can lead to further hypoxia. They should go see their doctor for it. It's very important for them to do that. The most important thing for our patients, again, for management of sickle cell is hydration, hydration, hydration. They should be really encouraged to drink lots of fluids every day, not only for maintenance, but then also if they go into a sickle cell crisis. That's one of our big components of treatment is hydration, lots of fluids. And then, of course, pain medicine as needed to treat the actual pain of the crisis. So speaking of crisis, when you hear of a sickle cell crisis, you'll also hear it called a vaso-occlusive crisis, because that's exactly what's going on. There is something occluding their vasculature, and most of the time this is going to be that clump of red blood cells that have sickled and gotten stuck together, like the Christmas tree ornament hooks, that you can never get apart until you straighten them out and declump them. So again, anything can cause this sickle cell crisis. Sometimes it's unknown what actually stimulates the crisis. Sometimes they can connect it to a specific event, such as a cold or a treatment. Treatment, hydration, and analgesia you see are the two bolded and highlighted because they are absolutely the most important. The rest are important too. Rest, the more they rest, they will often be put on bed rest, because the more they move around, the more they increase their cardiac output and the more stress they're putting on those cells to circulate and making the problem worse. As well as they'll do, if needed, electrolyte replacement, although that's not always a huge deal. It's going to depend on the cause. But blood replacement, if their anemia gets so severe, if they have so many cells that become sickled, that they have a dramatic drop in their hemoglobin, or so many cells destroyed by their spleen because of them not acting properly, they may need to get blood transfusion. And even though they're on that daily dose of penicillin, they may need additional antibiotics if they have an infection. So these are patients we really look at. So some fatal symptoms or some alarming symptoms we would look for in these patients, more above and beyond just your typical sickle cell crisis type of pain. Like I mentioned, chest pain is a huge deal in these patients because chest pain can indicate what we call acute chest syndrome. If they start having things like blurred vision or slurred speech, they can get strokes. They're more at risk than the general population to get strokes, again, because of that clumping of those cells. So those are some pretty significant symptoms we'd want to look for in this population. So to move on away from our red blood cell problems, let's talk about our clotting problems. So our most common one we talk about related specifically to pediatrics is hemophilia. So there are three main types of hemophilia. Hemophilia is just where there is a problem with clotting. And what most people don't realize is this is not a platelet problem. Their platelets aren't in any way defunct or inadequate. It is a clotting factor problem. And the general public oftentimes has never heard of clotting factors, so they immediately associate it with platelets. But there is not a platelet problem with this, it's clotting factors. And depending on which type of hemophilia they have will also depend on which clotting factor they have a problem with. So the most common ones that you do hear of are factor 8 and factor 9. Your most of them, as far as these two, are X-linked recessive, which means they are almost exclusively in boys. Von Willebrand disease, however, is an autosomal disease, so that means you will see it in boys as well as girls. So hemophilia A and hemophilia B are where it is a deficiency in the clotting factor itself. So with hemophilia A, you'll hear it called classic. This is a deficiency in that factor 8. Hemophilia B, you also hear it called Christmas disease, is factor 9 deficiency. With von Willebrand disease, it's not the factor itself that is deficient. It is where it is a deficiency in the von Willebrand factor. And what von Willebrand factor is basically the factor that calls factor 8 into play. So you've got factor 8 floating around just fine when you have von Willebrand disease, but it's inactive at that point. You don't have a bleed, so it's inactive. Well, when you have a reason to activate that factor, like you bump your knee, for instance, and you need that factor 8 to work to stop the bleeding, in von Willebrand disease, the factor that's supposed to call it to attention, to call it to its job, to make it function, is deficient. So these are patients, for instance, that may not have bleeding at baseline, but then when they go in to have a surgical procedure or a dental procedure or some kind of injury, they can't stop the bleeding. So with hemophilia A and B, you're more likely to just see idiopathic bleeding or bleeding that happens for no known reason. Von Willebrand disease, you're more likely to see it when an injury or some kind of insult to the body happens that would cause bleeding, because it's not that they don't have the factor, it's that they don't have the factor to activate the factor, which is your von Willebrand factor. So these bleeding disorders are a deficiency of those specific clotting factors depending on which type it is. So in your textbook, it does talk about the various manifestations associated with hemophilia. The most common one you see is hemarthrosis. Hemarthrosis is bleeding of the joint. So this can happen spontaneously without any kind of injury in your hemophilia A, hemophilia B patients, or it could be related to an injury. And this often depends on the severity, and this can vary from patient to patient. It could be where they have a nosebleed or epistaxis that will not stop. Sometimes that can be initially how it gets diagnosed. They can get things like hematomas when they get injections, much more prominent than you would expect from a typical patient who gets an immunization. So your big priorities in these patients, first of all, is to prevent bleeding. Anything you can do to prevent cases of bleeding once they are known to have this disorder. And then your second priority is to recognize symptoms of bleeding and control that bleeding. So if they have knee pain, for instance, it might not look like a big old purple hematoma from the outside. Just recognizing if they have decreased range of motion or pain in that joint, especially in the younger ones that can't verbalize as well what's going on in that joint, that could be a sign that would need to be addressed in these patients. So those are the priorities, is to recognize it, control it, and especially help prevent it, hopefully. So how do we manage hemophilia? Well, honestly, it is going to depend on the patient. So in the prison system, we actually had several patients with hemophilia. It was more common than some of the other stuff we had. So we had the way to treat hemophilia is giving them IV factor concentrate, either 8 or 9, depending on which type of hemophilia they have. It can only be given IV when we're talking about the factor concentrate. So depending on the severity was how often they would get it. I had some patients who would only get factor concentrate administration when they had an injury. So if they bumped their knee on the playground, even if they weren't having signs of bleeding, they would still get that factor concentrate infusion. I had other patients who automatically came in Monday, Wednesday, and Friday and got factor concentrate infusions 3 times a week, whether they had a injury or not. And one dose of this is $10,000. So very expensive medication. So for somebody to have to get it 3 times a week is pretty aggressive therapy. So it's all going to depend on that patient. And it could be PRN or as much as 3 times a week. So it could also be another medication that we use specifically for von Willebrand disease is your desmopressin or your DDAVP. So I know you've heard of this drug, even if you don't remember it. You talked about it when you were talking about diabetes insipidus. You can give that to decrease some of that excessive urination. It's your vasopressin. Desmopressin is the drug form of it. Another thing, just for your own fun fact that we use it for, especially in pediatrics, is bedwetting. We'll use it for that as well, and it decreases those incidents of bedwetting. So with desmopressin, the most common way we give it as far as a maintenance drug is through a nasal spray. It works very good. And this is usually for your von Willebrand factor or your more mild cases of hemophilia. So what are we doing for management? So number one, like I said, prevent bleeding. So creating a safe environment, promoting dental hygiene. If they don't have good dental hygiene, if they get even mild cases of gingivitis, then that can cause bleeding of the gums. That can not only increase their risk of infection, but can also increase their risk of bleeding problems that can go uncontrolled. So what if they have an incident of injury? What do we do? Rice. You know what rice is. You've talked about rice with your musculoskeletal injury. So rest, ice, compression, elevation. Those are your big management of hemophilia. So wrapping it up in an ACE wrap with some ice, elevating it above the heart, resting it, keeping it immobilized, splinting it even. So when we put that compression on it, they'll put a splint on it too, because the more you move a joint, the more bleeding that's going to happen. So if you splint it and keep it still, it will decrease that amount of bleeding that's going to happen at that joint. So on top of rice, we're going to give them whatever medication they need. So in this case, with factor 8, factor 9 deficiency, or even with your von Willebrand disease, we can give them factor concentrates, although they're less likely to give those with von Willebrand. But if they have a pretty significant bleed, they may give them that as well. So IV replacement of factor concentrates along with rice is how we treat an actual acute event of a hemophilia bleed. So as far as white blood cells, the most common disorder that we see in children is leukemia. There's multiple different types of leukemia. I know you touched on it in MedSurg 1. The most common type is ALL in pediatrics, or acute lymphocytic leukemia. It is the most common form of cancer in general in childhood. And this is a malignant disease, not of the blood, but of the blood marrow. So it is those blood forming organs, not the blood itself. But what we see is the problems related to abnormalities in those blood cells, because the factory is not working correctly. It's not producing the products that we need. So oftentimes you will see symptoms related to a global problem with their CBC. So they'll have their red blood cells, their white blood cells, and their platelets may all be off. Sometimes they are decreased because the factory's not putting them out enough, or sometimes, especially with your white blood cells, they may actually be really high, but your neutrophils are also really high with no indication of infection, which means that factory is pumping out way too fast these immature white blood cells, causing you to have that higher white blood cell count, that higher neutrophil count, but things that just don't work properly. And if you think of how cancer cells work, cancer cells are cells that rapidly produce. So with that rapid production is causing this rapid production of white blood cells, causing these abnormally high levels. So symptoms involved with this are often symptoms related to problems in those various types of marrow cells. So they may have a low-grade fever. They may have paleness, like at the low red blood cells, or fatigue. They may have signs of bleeding, such as bruising, petechia. They may bleed easily, like after a dental procedure or things like that, or they get a cut on their leg and it's not clotting like you would expect. The two most common symptoms usually you see are low-grade fever and leg pain, especially in the femur area, because if you think of the femur, that's a huge production factory for our blood cells. So every time my kids say they have leg pain, Of course, in my head, I'm like, it's just growing pains, but of course, I go right to leukemia. Probably one of the sickest patients I ever had that died within 6 months of diagnosis, which is pretty unusual for ALL, is a 9-year-old kid who the only reason his mom took him to the doctor is he kept getting low-grade fevers. He'd have a low-grade fever for a couple days, it would go away for a couple days, come back for a couple days. So it was just on and off for a little over a week or two, and took him to the doctor, and he had leukemia. That was his only symptom. And his was the most rapidly declining leukemia I've ever seen. So it can get pretty significant, although ALL, I don't know if it's because it's so popular and that's why we have so many not popular, but um, so common compared to other branches of leukemia and other pediatric cancer disorders. But it is also the best outcome of pediatric cancers that we have. It's got an 86 to 90% cure rate in children for ALL. Your AML, your APL, your other types of leukemias in children do not have nearly the success rates that ALL does. So it is definitely a leukemia that has some of the best outcomes. As far as diagnosis, the only way to diagnose leukemia is through a bone marrow biopsy, and this is with children as well as adults. So they can do a complete blood count to see, yes, we have a problem in our blood cells, but the only way to diagnose what type of leukemia you have is that bone marrow biopsy, which you see in the picture where they stick a needle into most commonly the iliac crest, and they will withdraw some of that marrow inside and test it specifically for what type. Why do we need to know what type? Why is it important? Because that can greatly change our regimen that we use. The types of drugs that we use can change based on that. We're also going to be looking at things like kidney function. How is everything excreted from our body through our kidney? So if they have impaired kidney function, we're concerned about potentially that they're not going to excrete that chemotherapy the way we need them to. Because unlike solid tumors, you can't do surgery for leukemia. You can't do, we don't typically do radiation as much. Chemo is the big gold standard. So they need to make sure they have adequate kidney function. So when we're treating these patients, what's very important, adequate hydration, because you want to make sure that chemo gets in the body, does what it needs to do, and gets back out as quickly as possible. And that will best give the best outcomes for these patients.